Hello, this is Dr. Jeff Gerber, and I'm here in Denver, Colorado, and I'd like to wish everybody a happy Thanksgiving for those who are celebrating in the United States. And I hope that you weren't too troubled by the food coma last night. In fact, if you ate low carb, you didn't have to suffer from food coma. I'd like to say hello to Glenn and Yael, who are the founders of Adapt Your Life, Low Carb Adapt Your Life. And it's Diabetes Month, and I think it's an honor to be here talking to you today about diabetes, chronic disease. And by the way, Glenn and Yael, my wife says hello. We have a few days off because of the holiday, and we were out yesterday taking a walk on the bluffs with our dog Athena. And I know you're familiar with that. You were here last year for the Low Carb Conference in Vail, Colorado, and we had spent some time together here at my home, and you had walked up in the bluffs, and I always think of the two of you whenever we do that. So first of all, a speedy recovery, Glenn. Hopefully you will recover from your shoulder surgery. And you're invited out to Colorado again in February. We have another big low-carb conference this year in Breckenridge, and hope that you and everybody else can make it. Everyone's invited. So I'd like to talk about chronic disease for a minute. And the current medical model is that chronic disease is a progressive condition, and there's not much we can do about it other than treating the symptoms. And the problem is that that approach doesn't really address the root causes. And the chronic diseases that we're talking about include obesity, yes, obesity, diabetes, and heart disease. And they don't happen all by themselves. In fact, if you go back 100 years, we didn't see epidemics of these conditions like we do today. And so something has changed. And clearly it seems to have something to do with diet and lifestyle. And we think about this, we look at the root causes. And things such as hyperinsulinemia, hyperglycemia, inflammation, oxidative stress, and advanced glycation all tell us that the root causes come from external factors such as lifestyle and diet. And unfortunately, most healthcare professionals don't get it. And this is really our goal, to help educate the general public as well as healthcare professionals that we have to focus on the root causes rather than treating the symptoms. Especially so when we consider that the cost of healthcare is escalating worldwide. We need to do something about it. And when we understand these root causes, it makes us think differently about the foods that we consume. And there are some general themes here. Firstly, that refined and processed foods containing especially sugars, refined carbohydrates, and these industrial and vegetable oils, which are highly atherogenic and inflammatory, when combined, drive our appetite, and that's not a good thing. And so the idea is that we want to eliminate processed foods. We want to reduce sugars, grains, starches, and these highly atherogenic industrial vegetable oils, and we replace it with natural foods. And in this context, natural fats, including saturated fat and monounsaturated fat, become metabolically neutral, and they address metabolic disease and the root causes. So what I'd like to do is to discuss general patient examples and how we deal with them in our office. So looking at the spectrum of diabetes. So firstly, we have type 2 diabetics that come in and see us, and they tend to be overweight, and when you measure the metabolic markers, there's signs of hyperinsulinemia, hyperglycemia, and had an error message there. But again, hyperglycemia, hyperinsulinemia, and other markers of inflammation. And they're overweight. And we best address it using a low-carb diet, a diet that's higher in natural fats, and it controls appetite. And honestly, it should be a default approach with these types of patients. And then we have the type 1 diabetics. And these are the individuals that never produced insulin in the first place. And what we found in our office is that we can greatly make an improvement in their lifestyle by, again, reducing carbohydrates in the diet. In our 26 years of medical practice, we've really come to realize that carbohydrates are non-essential. And the current American Diabetes Association guidelines still recommend a minimal amount of carbohydrates in the diet, namely 160 grams of carbohydrates a day. And to us, that's actually quite extreme. And so there's different levels of carbohydrate consumption that we recommend to patients. And it's all individual based on metabolic health or not metabolic health. But with type 1 diabetics, a very low-carb diet, perhaps less than 40 to 50 grams of carbs per day, while replacing that with natural foods, natural proteins and fats, enables them to significantly reduce insulin requirements. In fact, we have many patients where we've reduced insulin in half, and the goal is to get insulin down to perhaps 25 to 50 units per day that we supplement, while seeing them improve in other ways. And then the last interesting group is what we call the diabetics that have LADA, or latent autoimmune diabetes in adults. And these are the individuals, it's a very common story, that they seem to be doing fine up until a certain point in their lives. Usually it's in their 30s, and all of a sudden there was an event. Something happened, and they got sick. And they were full-blown diabetic ketoacidosis. A lot of them end up in the hospital, and they find out that they're diabetic. And we call this type 1.5 diabetes. And so earlier in life, they were able to produce insulin, but as time went on, their insulin production basically eliminated. The pancreas stopped working, and they need to take insulin. And again, for them, the best treatment is a low-carb diet because it reduces insulin requirement. If they've had a weight issue, it helps them with weight. And so you can see across the board for diabetes in general that a low-carb diet absolutely seems to be best. And there's still some controversy outside the low-carb community that this is somehow dangerous. And again, this is the approach that we've been using in our patients for now 17 years. And we have only seen metabolic markers improve. We've controlled appetite, requirements for insulin has reduced, and we believe that we've prevented heart disease. So again, it's just a wonderful approach using a whole foods diet. So let's talk about body habitus for a second. So we have patients that come to see us that have weight issues. And when we measure the metabolic markers, we can see for most of them that they have some type of metabolic derangement. In fact, recent estimates are that over 2/3 of the population are overweight or obese, and at least half of them are diabetic and pre-diabetic. Dr. Joseph Kraft, who studied insulin metabolism over the past 40 years, would predict that at least 2/3 of the population have a problem with hyperinsulinemia. And so the issue is that these individuals that have weight issues, we clearly want to address with a low-carb diet, a whole foods diet. And then we have an interesting group of people that we call skinny fat. So on the outside, they appear skinny, but metabolically, on the inside, they have problems. And in particular, we see the Asian population who suffers from this frequently. And I've actually have some new Korean friends who tell us that the obesity epidemic is running rampant in Korea. And so not only do they have individuals who are suffering from the skinny fat syndrome, but full-blown obesity and overweight is now existing in the Asian countries. And it probably has to do with westernization of diet. And we have the last group, very interesting, who are actually skinny on the inside, but they're not at ideal body weight. And so we actually have individuals that look metabolically normal, but again, they want to lose weight. And for these individuals, we really have to blend the approach. I think that a low-carb, a whole foods diet can control appetite, but in general, the goal with these individuals is to get them to eat less. In fact, across the board, that's what's so powerful about a low-carb, whole foods diet, is that it does tend to control appetite. I think even more so in patients that are diabetic. But in these metabolically neutral individuals, any diet, honestly, across the board that would control appetite would be a good approach. And so that's something that we have to consider. And it can include low carb, it can include ketogenic diets, it can include intermittent fasting, a high-fat Mediterranean diet. We even have variations of vegetarian low-carb diets. And so, again, when patients come to see me, I think if we can find ways to control people's appetite, to get them to eat whole foods, unprocessed foods, we're going to be helping the patients across the board. And that's where healthcare professionals need to learn. So lastly, we'll talk about heart disease and cholesterol. And really, we have focused on cholesterol for over 50 years, ever since lipoprotein was isolated in the blood back in the 1940s. And unfortunately, the emphasis when it comes to heart disease has been lipoprotein and cholesterol, and that remains true today. In fact, last week, the U.S. Preventative Services Task Force came out with a recommendation that really just mirrors what has been recommended from the American Heart Association in the U.S. and also from NICE in the U.K. And again, that emphasis is cholesterol and lipoprotein and medication when it comes to cardiovascular disease. And what we hate about that approach is, again, diabetes risk is absolutely buried. The calculators don't properly address blood sugar, blood glucose. It doesn't address insulin. It doesn't properly address metabolic disease. And when we look at the literature, we see that diabetes and prediabetes is tightly tied to heart disease. And it's unfortunate because we see diabetics who come to our office that have no idea that they have heart disease. And we also have heart patients that have no idea that they have diabetes. And so there's this big disconnect. And it really has to do with this emphasis and focus on cholesterol and lipoprotein. Now, I think in 2016, it is important to still think about this, but it is just overemphasized. And that's the point that I want to make clear to individuals. And especially so for primary prevention, when these new guidelines come out and the Preventive Task Force tells us that to address primary disease or primary prevention, that is preventing heart disease in patients who are free of heart disease, that the focus needs to be broad, not just looking at cholesterol. We need to address metabolic disease. And that's what we do in our office. And that's the message that we want the general public and healthcare professionals to understand. Again, the cost of healthcare is escalating, and I think our job as primary care physicians, I'm a family doctor, like a general practitioner, and I'm happy to report that globally around the world, we have a push of low-carb healthcare professionals that are trying to share this message. I'm involved with conferences now in the United States, and one of my goals is to invite healthcare professionals and offering continuing continuing medical education credits to entice them to come to these conferences so they can learn about nutrition. Unfortunately, it's the last thing on their mind, but it's our goal to educate. So that's all I have, and I hope you enjoyed our time, and stay tuned for more live events like this. Until next time, bye.